Good morning and welcome to our community panel on emerging ethical dilemmas that challenge our community. It's 9 a.m. and we are so excited that all of you have joined us. We're going to begin soon, but I want to start with introducing myself. I'm Tracy Gonzalez-Padron, the director of the Daniels Fund Ethics Initiative Collegiate Program at UCCS College of Business. I'm also professor of marketing, international business, and strategy at the College of Business. As we begin our panel event, we ask that you stay muted and turn off your video in order to focus on the information presented by the panelists. This morning, we will explore ways to address the increasing pressures on our community and healthcare systems created by emerging issues this past year. Our esteemed panelists offer diverse perspectives on the ethical dilemmas existing in our community setting. As the Daniels Fund Ethics Initiative at UCCS is a sponsor of this event, we will use these Daniels Fund Ethics Initiative principles as a framework to explore this issue during these presentations. We are also pleased to partner with the Colorado Springs Community Ethics Advisory Committee to present on the community health issues of today. So we have a full agenda of presentations on different topics. We ask that you consider questions as each presenter is speaking, and you can enter them in the chat. Keep in mind, everyone will see your question. So if somebody has already asked a question and you agree with it, we don't need to repeat it, but we will be checking these questions as we go through. And periodically, if we have time after presenters, we might ask some of the questions, but otherwise there is time for questions and comments at the end of the presentations. Our first presenter is Dr. Kathy Prue-Owens, an assistant professor in the Helen and Arthur E. Johnson Bethel College of Nursing and Health Sciences, which is one of our sponsors of this event. She is also the first UC Health Memorial Term Chair. Kathy is a retired Army Nurse Corps officer who served in the United States Army for over 30 years. She currently serves as the chair for the Community Ethics Advisory Committee and will offer an overview of the committee. Let's welcome Kathy to kick off the program.
Thank you, Tracy, and good morning, everyone. On behalf of the Colorado Springs Community Ethics Advisory Committee, we would like to thank the Daniels Fund for this opportunity to provide information about our Community Ethics Committee. In addition, will we present community ethic dilemmas and hope to initiate collaboration with you as community partners. So my name is Dr. Kathy Prue-Owens. I am the chair of the Ethics Committee. And to start this presentation with a number of topics, I'd like to start with an overview of the committee. Sure. The development of our Community Ethics Committee developed out of a necessity to assess the fire department with utilization of 911 and the ED, the emergency department. Our committee also focused on high intensity patients and had a professional desire to work with ethical issues in the community and within the hospital organizations. As you can see, conducting ethics ground rounds at Centura Penrose. Why our Community Ethics Committee centered on contexts of increasing collaboration, CDC emphasis, population health, and the accreditation for the public health. We identified that the community as a core needed an entity to assist with ethical dilemmas. We founded ourselves and created the Community Ethics Committee based on the needs of our community and the needs essentially within the nation. Our committee worked diligently to develop a charter that reflected our mission, vision, and ethical principles that are very similar to the Daniels Fund. The charter here is just a glimpse of our collaboration efforts and our awareness of the ethical challenges our community faces. Our charter has objectives that are reflective of education, policy development, consultation, ethical discourse and dialogue, compassion and debriefing of community partners. The committee has outcomes, a structure, and evolving procedures. Here is our mission statement. We exist to provide a broader community-based view from a medical ethics perspective on issues related to healthcare and wellness. The committee also provides review and recommendations as well as medical ethics related education to and in collaboration with local agencies and resources. So our intent is to definitely be a link and a partner with our community on ethical issues related to healthcare. The committee's goals related to collaboration include that we do recognize the impact of clinical, resource, and behavioral facts and values on ethical, complex decisions. We also want to look at our goal of clarifying our core personal and professional values and how those inform the lenses through which we look at ethical issues. We want to be able to define various stakeholders that value proportions in ethical contexts. So we like to bring the different stakeholders in, and you'll see from the panel today that we do have a number of stakeholders, not within just the committee, but with also that are representative of the community. We also want to have one of our goals as describing our ethical frameworks, our tools and approaches to engage in patient families and agencies, and even communities, which is our goal, a major goal of our committee when we're facing ethical conflict. We want to be able to develop skills and relationships that support the process of ethical deliberation. Our last goal, and not really necessarily our last, but we always have these evolving goals that could potentially change based on the needs of the community. But we do want to consider the unique perspectives about quality of life, the distribution of resources, as you'll see in one of our presentations today, ownership of challenges, and shared decision-making. Our ownership of the challenge comes with all of us as individuals who make up the community. To go over our objectives just in a little bit more detail, our first one is the education. The committee helps educate the community and the public in collaboration around ethics, in particular maybe in a certain population or a certain policy. And so this education extends into the community through collaborators in the program or the meetings of this collaboration. So we hope that one of our goals with our presentation is to be able to have collaboration with you in the community and develop partnerships. A second objective is the policy development. The committee may help to develop or revise policies on ethical perspectives associated with the policy that is being brought forth to the committee. Our third objective, consultation. The committee will review specific cases that are referred from the Colorado Springs Fire Department or community partners. That could be any of you sitting out there listening to this today. That review of cases is to provide that ethical perspective and give suggestions and considerations for the ethical dilemma. Our fourth objective is to look at ethical discourse and dialogue around patients and ethical concerns surrounding their care and alternatives. We as a committee have looked at community cases related to patients in high utilization situations in the emergency department. So our objective is to be able to have that dialogue and be able to have that conversation about the ethical concerns that come up in reference to situations like that. Our fifth objective is to be a compassionate and debriefing of community partners. We want to be able to link and partner with those out in the community in reference to ethical dilemmas that may be coming up. And you'll see from today's presentation that we do have a number of ethical dilemmas that are faced in the community. The committee values outcomes related to our mission and vision of community ethic reviews and partnerships, accountability, increased awareness, development of policy and program integrity for present and future excellence and sustainability. Our goals include support of partners and community when faced with difficult ethical situation. The dialogue between even inpatient and community resources is important. Our continuum of care and our community treatment plans to disseminate best practices and sustainable care is our last but not final outcome as we as a committee move into the trajectory of partnership with the community. So our first presenter today is Dr. Carl Middleton. And we get papers here. Dr. Carl Middleton has served as a vice president for theological and ethics located in Catholic Initiatives in Denver office. Dr. Middleton has facilitated the Catholic Health Initiatives discernment process for major decisions, including 103 acute care facilities and 48 long-term care and assisted living facilities in 18 states. Carl joined the Catholic Health Initiative Texas Division as an interim senior vice president of mission and has served in that role since 2018 when he retired. During Hurricane Harvey, he served on the division incident command team and partnered with human resources to care for 654 employees who were displaced due to the hurricane. Dr. Middleton has had extensive work record, including teaching ethics in Catholic seminary, nursing schools, medical residency programs in several universities, serving as director of pastoral care, vice president for mission and human educational services, corporate director of values, ethics, and ministry. He also has served as vice president for theological and ethics for 2 other Catholic healthcare system, and currently serves in that role as the Health Initiatives. He is the past president of the Colorado Healthcare Ethics Forum Board and on the American College of Healthcare Trustees Board, where he is the senior vice president for ethics and the chief operating officer. Carl has been a dynamic speaker, has co-authored books, numerous articles, has given numerous presentations on a number of topics to include values, mission integration, clinical organizations, social ethics, values-based leadership, corporate ethics, moral leadership development, ethics committee. During his retirement, Carl is active in consulting and serving on boards. So our next speaker is Dr. Carl Middleton.
Thank you, Kathy, and good morning, everyone. Have you ever wondered what happens during a disaster or pandemic when the demand for hospital beds and or ventilators in a particular community outnumber the supply? This brief presentation will answer this question for you. But first, a bit of history. Back in 2009, at the height of the influenza A, or more popularly known as H1N1 pandemic, several government agencies asked the Institute of Medicine to provide guidance. And the Institute of Medicine convened a committee of experts to develop national guidance for use by state and local public health officials and health sector agencies and institutions in how to respond to the healthcare needs in a pandemic or disaster. The Institute of Medicine established and implemented standards of care that should apply in disaster situations, both naturally occurring and man-made under conditions of scarce resources. So what are crisis standards of care? Well, when there is a substantial change in usual healthcare operations and the level of care, it is impossible to continue that level of care, which is made necessary by a pervasive pandemic influenza or catastrophic, such as tornadoes, earthquakes, and hurricane disasters. And these are the standards that would say, how do we continue to provide safe and quality care during this disaster? Ethical norms in medical care do not change during disasters. Healthcare professionals are always obligated to provide the best care they reasonably can, given these dire circumstances. Now, there are several substantive principles, or we might say ethical norms, to guide decisions, and that is fairness. There's a duty to serve. We need leadership, and we need proportionality. That is that the response is proportion to the needs, and then protection for the healthcare providers, the protection for the patients and the community. There are some procedural principles, in other words, ethical processes to follow when making these decisions, and that is first and foremost is inclusion. That we need to include as many people as possible. Transparency, that we're open and we honestly communicate, and then we're consistent in applying the ethical principles and norms, and then we are held accountable for our actions and our behaviors. So some of the rules for rationing in a crisis: yes, the greatest good for the greatest number, but we also have to consider saving the most lives, save the most life years, save the most productive quality life years, keeping in mind women and children first, and also to the extent that we can, first come and first served. We need to make it market-based, protect the most vulnerable, promote social justice, maintain social order, minimize economic impact, being good stewards of the scarce resources, ensure continuation of a good society, and respect and care, provide compassionate care for the dying. So what about Colorado Crisis Standards of Care? The Crisis Standards of Care was developed this past year and was approved for Colorado April 9th of 2020. The Colorado Crisis Standards of Care need to be activated by the governor or his designee. Colorado health facilities have been organizing and training since April of 2020, have been training healthcare professionals to participate in making decisions regarding triage allocation of scarce resources, including beds, ventilators, staffing, and personal protection equipment. At this time, the standards of care have only been called into effect for EMS services and protective protective equipment usage. So what happens during a triage approach? That we make allocation decisions based on evenly applied practices, and we try to be as fair as possible across the spectrum of patients in making decisions about how to best use the limited medical resources. So Colorado's crisis standards are based on a 4-tiered triage system of allocation of scarce resources. The first tiered decision process starts with an assessment by the triage team and a focus on a patient's acuity and comorbidities. And we use the SOFA score and the Charleston score for comorbidities. If 2 or more patients want and need the same resources and have the same score, then the triage team should consider additional prioritization criteria. So let me give you an example. Judy is a 47-year-old nurse, and John is a 47-year-old EMS paramedic. Both have the same scores of 4, both are diabetic, and both have COVID, and they need an ICU bed, but there is only one ICU bed available. There is a tie. So we move to the second tier decision process. This gives priority to pediatrics and first responders and healthcare workers. There is still a tie because both are in healthcare. The third tier decision process gives priority to the number of lives saved. Since both are of the same age and have the same comorbidities, there is still a tie. So the fourth tier process, where all considerations remain equal, we use the random allocation. And what is that random allocation? We basically put their names on separate pieces of paper, put it in a hat, and pull out one. And that's the person that gets the bed. Now, you say, well, that's not very complex. But remember, we've been through 4 tiers of this process, and we had to be able to make a decision and award the bid to someone. But let me just say, to date, thank goodness, we've not had to triage beds and ventilators. As of last night, we are in the state of Colorado, we are in good shape in terms of having the necessary amount of beds. Should we have a rush on ICU beds or on ventilators, we are in good shape in terms of that. So in summary, the crisis standards of care have been implemented to date for staffing, EMS, and PPE, not for beds and ventilators. The CSC had been implemented for beds and ventilators for just a few of the Colorado health facilities that have the shortage, that have a shortage, but not statewide. And that's been primarily on the Western Slope. But those patients were transferred to other facilities that did have the availability of beds and ventilators. Crisis standards of care are currently being developed for long-term care, palliative, and hospice care. This crisis standards of care upholds the following Daniels Fund principles: integrity, trust, transparency, fairness, accountability, respect, and rule of law. And so these crisis standards of care, and we have trained healthcare professionals that will be able to implement this should they be needed. Thank you for your attention this morning.
Thank you, Carl. Our next speaker is Dayton Romero, and Dayton is a Colorado native and alumni of UCCS and is a Master of Public Health candidate, concentrating on leadership and public practice at Anschutz Medical Campus. Dayton has a passion for the field of aging and has gravitated toward the interest of leadership, systems alignment, and strengthening the economic and social well-being of people across the lifespan. He serves as Director of Silver Key Senior Services and oversees the health and wellness programs. Dayton is a strong advocate for the aging community and is involved in many initiatives locally, statewide, and nationally. He has been featured in Colorado Springs Gazette and the Colorado Springs Business Journal as a mover and shaker. He is also spotlighted in the American Society of Aging Conference of 2018 and is a proud alumni of the American Society of Aging Leadership Institute. Dayton is currently volunteering and is a chair of the Pikes Peak Elder Abuse Coalition and Colorado Coalition on Elder Rights and Abuse Prevention. He's also the president of the Innovations in Aging Collaborative Board of Directors and board member of Rocky Mountain Healthcare Services, PACE. Additionally, he serves on the El Paso County Adult Protection Team and Mental Health Task Force and the Age and Friendly Colorado Springs Committee. Dayton enjoys the outdoors and enjoys time with his dogs, Dexter and his sweetheart, Celeste.
Thank you so much, Kathy, and thanks again to the Daniels Fund for inviting us to share a little bit about what we do and kind of show the diverse perspectives and the wisdom that this advisory committee has. And when I like to think the magic happens whenever those cases are in front of us to really kind of bring forth the wisdom that takes place. So with that said, I'd like to advance the slide, if I may, and talk a little bit today about three kind of overlaps, and that's the COVID-19, how the pandemic has really intersected with the social determinants of health, and particularly the impact on older adults in our community. And so with that, I'll bring up some statistics at a national level. I'll also talk about some initiatives that have gone on community-wide and some other anecdotal information that I've experienced firsthand here in our community, both on a kind of cross-sector collaborative basis, as well as kind of my insight here at Silver Key as a primary senior provider in our community, where we serve around 12,000 seniors annually through multiple critical supports for them. So with that said, I'll dive in with my intro here. It's no surprise that COVID-19 is changing older people's daily routines. The care and support they receive, their ability to stay socially connected, and how they are perceived. Older people are being challenged by requirements to spend more time at home, lack of physical contact with other family members, friends and colleagues, temporary cessation of employment and other activities, and anxiety and fear of illness and death, their own and others. It is therefore important that we create opportunities to foster healthy aging during the pandemic. With that said, I'd like to go with the first here, social determinant of health, of food security. At the end of 2019, before the pandemic, food security was already upending daily life. 1 in 7 adults, 14%, aged 50 to 80 years old, experience food insecurity. Food insecurity being that difficulty acquiring healthy food due to insufficient financial resources. In December 2019, nationally representative poll of 2,050 adults aged 50 to 80 years old in the US were found that among those who experienced food insecurity, 42% had severe food insecurity, meaning they had to sacrifice the quality or amount of food they consumed because they lacked sufficient resources. Food insecurity is associated with many adverse health outcomes among older adults, including poor physical and mental health. The health consequences of food insecurity have almost certainly become more pervasive as the COVID-19 pandemic has disrupted daily life and routine health behaviors, as well as financial hardships for many older adults. Additionally, the COVID-19 pandemic has illuminated the precarious position many US residents are in regarding food security. As the economy shut down and stay-at-home orders were into place, individuals lost their jobs and incomes, and rates of food insecurity rapidly climbed. Older adults were particularly susceptible given that they had to navigate new ways of procuring food while they sheltered in place to avoid exposure to COVID-19. Therefore, as the pandemic evolves and the economic efforts continue, it is critical that policymakers ensure that a robust suite of policies and programs are in place to provide food assistance to older Americans who need it. And anecdotally, again, from our perspective at Silver Key, we've seen some of these priorities in action. And some of these policies come into place through the CARES Act funding. One was the strengthening of the SNAP program, increasing accessibility to this benefit. For those of you who may be unfamiliar with SNAP, it is the former food stamps, which is a public assistance benefit based upon income. And so the accessibility was made more streamlined for older adults and for everyone in general, but it was particularly strengthened there. And another one was to expand the Older American Act nutrition program. Now, for our community specifically, our Area Agency on Aging is the administrator of these funds, and we partner with that. Silver Key partners with the Area Agency on Aging to deliver two very critical programs to our community for older adults, which are the home delivered meals, Meals on Wheels, and the congregate meals programs. And with that, we'd seen a double in the need. We'd seen a spike in need double for older adults who were enrolling in that program. So we were getting meals out. I believe we went from delivering 7,000 meals a month to over 16,000 meals a month to the seniors in our community. So those resources are absolutely critical to be able to deliver and get food on the table for many. Additionally, providing additional funding to support food banks. So Care and Share is a prominent key stakeholder in our community, as is Silver Key. We collaborate with them, and through that, we've been designated as one of the largest. Silver Key has been designated as having one of the largest food pantries in Southern Colorado, distributing approximately last year over 1 million pounds worth of food, and that's near 80,000 pounds worth of food per month. And so many seniors are dependent upon these critical services, and the resources to do that are absolutely critical to plug in that way. Our pantry has made extraordinary efforts to meet our clients where they're at, from creating an express lane model where people were coming in and picking up prepackaged food for a month's worth of grocery items, to getting those items delivered for those who were unable to get out of their home or were facing any sort of transportation barriers, which we will talk about transportation here very shortly. Environment and safety. So when I think about environment and safety as it relates to social determinants of health, creating environments that protect one of the most vulnerable and at-risk populations was absolutely critical at the beginning stages of this pandemic, and it continues to be so. We've seen right here in our community and statewide, we've seen cross-sector collaboration that has brought forth innovation and just intriguing supports for older adults to create that environment and really bring forth their safety. There's also been some very contentious sort of safety parameters put in place, which have to do with the care facilities. And I'll talk a little bit more about that within the housing domain, but that particularly has been a contentious sort of a conversation from ombudsmen not being considered as essential workers and not being able to get into the care facilities to be able to advocate for the residents, and also with families having very limited ability to see their loved ones who may be in the ending stages of their lives, or just just in need of support or that connection. So those pieces have been brought forth and have been discussed in depth among many groups and continue to do so today. I think additionally, when I think of safety, which is, we normally think about environment and safety of those guidelines that have been given with the masks, with the social distancing, but one that is oversighted that particularly relates to older adults is elder abuse. And at the beginning stages, and I think continuing today, we've seen efforts among scammers really get creative where they're looking at, trying to sell older adults on fake testing kits or, alternative cures. And those telephonic sort of efforts are taking place on a daily basis. We've seen too many cases, in my opinion, where older adults are receiving persistent phone calls who are from scammers who are trying to leverage this pandemic as an opportunity to take advantage and financially exploit many adults, older adults in our area. So that is on the radar of our local adult protective services and our police department, who has dedicated staff and resources to spread the word and educate. Now, access to healthcare. When I think of access to healthcare, again, particularly for older adults, I think about the advances that this pandemic has really pushed us into when it comes to our technological infrastructure and the use of telemedicine. Accessibility is so critical in these times, and at a time where we're looking to keep ourselves safe, whether it be staying at home more or whatever the case may be. So navigation in itself is tough. So telehealth and the increase of use of this among providers, I've seen an increase in that. And again, just from the Silverkey standpoint, I could speak to, we've vamped up a lot of our efforts to be able to meet people where they're at and explore that telehealth. And we could go to the next slide as well. These have the, they reflect one another, and the next slide is a little visually aesthetic. So additionally, the vaccination comes to mind as a means of access to healthcare. And I know Robin will be able to speak to a lot more eloquently than I can, and a lot of the plans and efforts and energies that are going into it. But I additionally think about, in terms of access, information and communication dissemination, and the efforts in order to minimize confusion and be clear on how older adults can gain access to the vaccination as being one of those prioritized groups. So, and right here in our community, we've been very fortunate to see collaborations come forth where the county and the city and other key stakeholders who serve older adults are coming together to plan and all be on the same page in terms of what they're communicating, so it's clear and minimizes that confusion. The hotline is, as a result, through the Pikes Peak United Way, that is a result of those collaborations and those conversations that are going on behind the scene to address that. Now, housing is it's a robust topic whenever it comes to social determinants of health, and what comes to mind is the Maslow's hierarchy of needs. If we don't have shelter over our roof, then we can't focus on our behavioral health, and so on. So the consequence and the ripple effect that a compromised housing situation may have for someone is particularly an issue, and honestly was one that preceded the pandemic and was only magnified whenever these issues, whenever economic hardships start coming forth. When it comes to housing and older adults, I think of the fixed incomes, and fixed incomes with a sample size here at Silverkey, we'd had around 12,000 again. We've seen an average of around 1,200 dollars per month via Social Security. And so if you coincide that with a competitive housing market like a Colorado Springs, where the average rent for a 1-bedroom is close to $1,300, then we're looking at very tough situations in terms of navigating and finding alternative housing. So those sort of pieces come into play when this pandemic has hit. The eviction moratoriums have also played a big role in people in actually the dynamic between tenants and landlords, where you know those subsidizing sort of resources are really having to be tapped into, and a lot of mediation and a lot of conversation has had to be had in order to, one, prevent older adults from really becoming homeless, and also the property managers able to cover their costs as well to be able to maintain. So next is income. And again, I'll refer to those who are lower on the socioeconomic status, who do have that average amount of $1,200 per month. And again, affording rent, really paying for those basic costs. Too many times we've seen older adults who are in those situations where they're having to make a decision between paying for their medication, paying for their utilities, paying for their food, or paying for their housing. So it's one or the other. Do I eat today, or should I pay my rent? And so the critical supports that are out there and ensuring that they're aware of these resources and have an accessible link to them are absolutely critical, especially those who are lower on the socioeconomic status. When it comes to workforce, which the senior population particularly, again, has challenges in this, and again, compounded by the economic climate and the limitations that the pandemic has put on many, this is only, again, amplified, and that again poses challenges where it depends on again navigating and more strenuous sort of hoop jumping, if you will. I think about the workforce additionally in terms of volunteers and the critical sort of the support that they've provided our community in the time of need, and the contribution to the resilience of our community that they've had. At Silver Key, we've had to make extraordinary modifications to many of our programs, and have been very fortunate not to skip any beats in any one of our critical supports. And we could not have done that without the support of our volunteers. And we've seen volunteers who we've never seen before come out and volunteer and provide those supports for us at a time where, you know, they were in a hardship themselves. So some were furloughed, some were, you know, laid off, and they were reallocating their time and energies and efforts to contribute to the community in this way for our seniors. So that kind of collective effort has been very powerful for us to remain resilient. Social isolation has been a very prominent topic whenever it comes to seniors. It poses a huge risk factor for behavioral health, for physical health, and social isolation has been, we've seen an uptick in it because of the encouragement of staying in home or keeping physical distance. And so it's been those instructions and that guidance is a little counterintuitive to what we're really trying to engage seniors in terms of their activity of getting out and getting active and being social, because those are all really good. They're all great for health. And so this sort of flip on the dime, we've seen efforts, again, in these collaborations that have come forth where, you know, whether it's a telephonic solution, calls of reassurance, where we have volunteers outreaching to older adults to have those lighthearted conversations and be the eyes and ears for behavioral health providers and knowing how to connect them to resources, all the way to telehealth and to virtual tours. So we've seen some creativity to really engage and embrace that virtual world and keep our seniors from being socially isolated. I also, with social isolation, again, go to the care facility contention, and the ethics involved in that conversation are very complex, given the consequence of decisions that are made from multiple levels and jurisdictions. And so that is kind of an interesting conversation that I would be happy to connect offline on, and I'd be happy to provide my information. But if you're interested in that, I'd be happy to connect afterwards. And that is one that is also on the radar of a statewide organization called the Colorado Senior Lobby. Two more here in culture and our transportation. Transportation has been identified as one of our highest needs in our community, especially for older adults and the access to it. The pandemic has posed issues whenever it comes to the scale of need and balancing with keeping those individuals safe who are relying on the different transportation services to, get to dialysis. And so those balancing acts are very critical conversations to have of how do we meet the need and how do we at the same time get individuals to very critical places like the grocery store, like to dialysis and other treatments. Culture and language, I think, is an important determinant of health. And again, with the pandemic, it's amplified the disparities, the health disparities among minority groups. And so just keeping an eye and being very intentional on the equity efforts whenever it comes to communication of available supports are absolutely necessary, whether it being having multilingual supports available, and being very, having a good idea and awareness of where these different groups get their information and how we, disseminate that information in a culturally sensitive way. Lastly, impacts here in our community. I've said throughout, I am very encouraged by the embracing of the resilience and by the embracing of this moment, and really looking to one another to build that resilience in our community, knowing how to respond, think on our feet, and become innovative. I know this concept through public health called positive deviance, where a group of people are all under the same identical set of circumstances, and this one group uses those circumstances and the tools within those circumstances in a slightly different way and are successful, while others are struggling or challenged. And I really see our community as being a positive deviant and embracing that resilience. And so with that, I am encouraged by moving forward, and I'm especially encouraged by how older adults are on the radar, and the community's issues at large are on the radar and being responded to appropriately and timely. And I know that may be a contentious word, but or a contentious phrase, but I deeply am encouraged by many of the individuals who are working hard, diligently, tirelessly toward addressing a lot of the issues we're seeing right here at home. So thank you.
Thanks, Dayton. We are going to go ahead and move right on to our next speaker. Okay. We are very delighted that over the last few years that we have had students on our ethics committee. And so our current student is Sarah McInerney. I always mess up her name, but Sarah is originally from Severna Park, Maryland. She has a BA in political science and philosophy. And upon graduating in 2006, Sarah commissioned as a second lieutenant in the United States Army, where she served on active duty for 9 years and deployed twice in support of Operation Enduring Freedom. And after transitioning from active duty into the U.S. Army Reserve, Sarah's interests shifted towards military mental health and resilience under her mentorship of Dr. Charles Benight Chip. Sarah hopes to learn more about factors that promote resilience and protect against the harmful effects of traumatic exposure. And Sarah's been on the committee getting close to a year now. So I am going to let Sarah present her slides. Sarah, you're muted.
Yeah. Oh, sweet. Awesome. Yeah. Good morning, everyone. Thank you, Kathy, for the introduction. Again, my name is Sarah, and I'm a second-year graduate student at UCCS, where I am studying to earn a PhD in clinical psychology with an emphasis on trauma. Next slide, please. I'm going to provide a brief overview on my role as a student on the Community Ethics Advisory Committee. Additionally, I wanted to share my perspectives on the value of having a student member on the committee with regard to the professional development for students and emerging clinicians and the unique perspectives that a student can provide the committee. First and foremost, my engagement on this ethics committee provides me with a unique and important learning opportunity. As a clinician in training, having the opportunity to see the kinds of ethical dilemmas affecting the community exposes me to the types of challenges I will likely face once I complete my training, as well as it allows me the chance to start honing my own ethical decision-making skills. Further, my participation on this committee provides me with a chance to interact with other kinds of professionals in the community. Thus far, my program, I have largely only been exposed to psychologists. And as a psychology student, most of my ethical training has centered on the American Psychological Association's Code of Ethics. The Community Ethics Advisory Committee consists of nurse practitioners, physicians, ethicists, mental health professionals, and other community members. And I am able to learn directly from these professionals in the context of ethical decision-making, which helps to broaden my perspective, which I can then bring back to my program and pass along to my peers as well. As a contributing member and freshly baselined with ethics training from my program, I'm able to offer the group insights from the most, you could go back, yeah, please, thank you. With insights from the most current ethical guidelines as they're understood and currently taught in academia. Additionally, I'm able to offer insights from a student perspective. And I find there are often many unique and specific concerns that seem to affect students very differently compared to other community members. And as ethical dilemmas are discussed, I am well suited to identify student-specific concerns and think about ethical questions as they relate to students specifically. During the course of ethical discussion, there's value in my lack of experience and expertise that students have. Specifically, if there's something I don't know, there's value in exploring the reasons for why I may not know something. This knowledge may reflect a gap between professions, something that may not be intuitive to community members at large, or a personal professional growth edge, or something else. Next slide, please. So including a student on this committee provides long-term benefits to the community in two ways. First is by students learning how to communicate among different medical professionals. I find there are slight variations in the specific kind of language used by different types of clinicians, that they tend to conceptualize problems differently and emphasize different concerns. By learning how to engage in a shared understanding early in my professional training, I am able to develop competency in working with other professionals beyond the fields of psychology and mental health. Second, students are able to learn how to trust the collaborative decision-making among professionals and how to trust the decision-making process from other fields. My participation on this community thus far has provided me with a positive experience that has allowed me to see how other professionals approach ethical decision-making within their respective ethical frameworks and appreciate the differences in their processes while ultimately arriving at a mutually agreed upon guidance. And thus far, I have learned a few things from participating on the Community Ethics Advisory Committee. First, I've seen how a diverse group can take a big problem, conceptualize it in a collaborative and meaningful way, and identify important themes to which we ultimately provided ethical guidance. Witnessing how a group dynamically and fluidly considered the broader concerns related to the COVID-19 vaccine dilemma and teasing apart the important themes that were important to address was an invaluable experience that I'm not sure I can fully articulate. Second, learning the language used by medical professionals was very enlightening for me thus far. I find that oftentimes in psychology, we use the same words, but we might use them differently. And I'm going to provide an example, and it might just represent my own shortcomings and inexperience as a student, but I'll provide it anyway. But for this example, during the course of the discussion with COVID-19, one of the themes that came out fairly early in the discussion was the idea of reducing comorbidity. And comorbidity is a word I'm familiar with, but the phrase reducing comorbidity just took me a minute to get my head wrapped around it, because at least at this point in my training, it's not really a way I think about conceptualizing a problem, or in terms of figuring out clinical treatment, or just thinking about it. It's just not a way I think about it. Once I figured out kind of what everybody was talking about and what it meant, I understood what the group was kind of getting at, but it did take me a minute. And lastly, I've seen how to approach ethical problems and provide meaningful guidance. I saw the group start from more broader guidelines and consider how various guidelines aligned with one another, and then how they started to narrow their focus to more specific concerns to which they ultimately provided guidance. In this way, the guidance that we ultimately provided was very specific, and it's still aligned within the broader ethical guidelines and imperatives. And again, I want to thank you all for listening to my portion of the presentation and your interest in the work that we're doing on the Ethics Advisory Committee. Pending thoughts or concerns from the group, that completes my portion.
Thank you, Sarah. I apologize for going on that next slide too, because I was.
Oh, no worries, no worries.
Okay. Our next speaker is Dr. Carol Traylor. Carol is Associate Chair for the Department of Nursing and Graduate Program Coordinator in the Helen and Arthur E. Johnson Bethel College of Nursing Health Sciences here at UCCS. She's also an assistant professor in the college teaching graduate nurse practitioner students, and she has been a member of this committee since its inception. So Carol has a lot of background and knowledge about our goals and moving forth with our committee. So go ahead, Carol.
Thank you, Kathy. Good morning, everyone. As a healthcare provider at the beginning of this pandemic, I had concerns about the lack of enforcement regarding individuals not wearing masks, social distancing, when the governor had put out mandates to address those things. Some communities did not follow mandates for large gatherings at all, and it seemed that law enforcement should be actively involved in enforcing the governor's mandate. So I did some research to look into the role of law enforcement and their position regarding enforcement of mandates during this pandemic. This will be a brief look at some of the ethical dilemmas facing law enforcement. The primary mission of law enforcement is to maintain public safety and prevent crime in the community. Each officer has discretion regarding his actions in any given situation. Law enforcement also has a role in establishing a relationship with the community, in addition to relationships with local and state government. So let's look at the mandates. the stay-at-home order. Should law enforcement stop individuals and question them if they are out and about? What about wearing a mask? Should law enforcement be the individuals that prevented a citizen from entering a business because they're not wearing a mask? How about social distancing? Is law enforcement the right people to disperse a gathering of people? Ethical dilemmas include whether to enforce mandates or not to enforce. And many agencies struggled with the issue of whether or not enforcing the mandates was a health issue or was it a criminal or legal issue. So conflicts were definitely identified. The impact on community relations if enforcement did take place would be critical at a time when rebuilding relationships in a positive way with the community needed to occur. And who are the stakeholders here? Certainly the citizens in the community, the law enforcement officers, and the government, each having their own point of view of what is right and what is just. Police are already short-staffed, so to take on the impossible task of enforcement did not seem likely. Certainly, once the mandates were put out there, they immediately became politicized as a result of negative role behavior seen at the higher levels of government. And with the enforcement, there was no funding that came associated with that. So for police departments and agencies that are already in a budget control situation, it would be an impossible mission for them to try to enforce this. So let's kind of look at two legitimate positions, two sides of the coin. The first one is to enforce the mandates. Certainly, this would be an unpopular mandate activity at the time of the pandemic. Using force against citizens to push for compliance is not a usual thing that the police department are responsible for doing. Certainly, fines and citations could be part of the punishment for non-compliance, and individuals arrested for defiance of the mandate could be arrested and put in jail. And as we know here in Colorado Springs, the jail became a super spreader. So increasing the number of people that you're arresting for defying the mandates and putting them in jail only increase the risk not only to law enforcement as far as infection rates, but also to the community for infection rates. So there were some areas of the country that had fringe groups that actually intentionally tried to infect police officers. So let's look at the other side of the coin as far as not enforcing. Education about the importance of the mandate for the community allows citizens to make an informed decision. Encouraging voluntary compliance certainly is more successful than forcing the issue. Therefore, by education and encouraging compliance, citizens assume the risk of the infection. Different counties, cities within the state are doing different things, which just adds to the confusion about what our community should really be doing. It's an impossible mission because of manpower and infection rates among police officers to expect them to be able to take an active role in enforcing this. Certainly the mixed messages from federal government caused a lot of confusion, and certainly it caused mistrust. So what are the dilemmas? The timing of the mandates and the riots against police brutality was unfortunate. At a time when repairing the relationship with the community was critical, punishing citizens because of non-compliance did not seem an appropriate action. And certainly punishing citizens conflicts with the traditional role of the police department. Protection of the officers and protection of the community was the bottom line. So let's look at some of the Daniels Fund principles that I felt were relevant to this particular discussion about whether law enforcement should be responsible for enforcing the mandates. The first one is trust. build trust in all stakeholder relationships. Certainly the impact of law enforcement would be apparent on the community as a stakeholder if they took on the role of enforcing the mandates. Respect is the second principle. Honor the rights and freedoms, values and views and property of others. Awareness that individuals make a choice to comply or not comply is respectful of the citizen. The third is the rule of law. Comply with the spirit and intent of the laws and regulations. Personal freedom is challenged by enforcement. So these principles I felt were directly reflected in some of the discussion around law enforcement. So in summary, I would like to just summarize some of the issues. Voluntary cooperation for you, your family, and your community helps to provide cooperation amongst the citizens of the community and provides legitimacy to follow the mandates. Messages need to be clear, they need to be accurate, and they need to be current in order to inform citizens so they can make an informed decision about their actions as far as following the governor's mandate of mask wearing, social distancing, and minimizing group gatherings. So I hope this has helped you to kind of reflect on some of the issues around the law enforcement issues and the enforcement or not enforcement of these mandates. Thank you for your time.
Thank you, Carol. Our last presenter is Dr. Robin Johnson, and then after this presentation, we'll wrap it up and we'll take some questions. Dr. Robin Johnson has 28 years of medical practice and healthcare advocacy in the Pikes Peak region of Colorado. She received her doctorate in medicine from University of Colorado and completed emergency medical residency with a Denver affiliated residency. She also holds a certificate of medical ethics from Catholic Health Initiatives and a Master of Public Health from the George Washington University. She practiced emergency medicine at University of Colorado Memorial Hospital in Colorado Springs for 24 years, served as medical director for one of the local safety net clinics, Mission Medical Center, and has served as deputy medical director for the Colorado Springs Fire Department Community and Public Health Division. Dr. Johnson is currently practices as a medical director for El Paso County Public Health and serves as adjunct faculty for UC Health School of Medicine. Additionally, she has continued to serve on many local boards in the Pikes Peak region, participates on the Community Ethics Advisory Committee, and chairs the Peak Vista Community Health Centers Board of Directors and the Behavioral Health Steering Committee for El Paso County.
So, well, good morning, and thank you for this opportunity to be here. I have to say, I want to start with a couple of comments from our previous speakers. When we think about positive deviance, I think right along with that goes disruptive innovation, which has been one of the drivers within my practice. Having been in the emergency room, it's a great litmus test for what is happening in culture. And through collaboration, cross agency and cross sector innovations, really working for collective impact and systems change, it became evident that we practice ethics every day in the decisions, and they are uniquely positioned when we're doing so throughout community relationships. And so when we look into the difference between our public health kind of level of consideration of ethical dilemmas, it typically is that public health actions are from the government directed at a population level, which can differ from guiding actions which are driven through biology or clinical medicine, which is centered on an individual. And there has been nothing, as you've heard from our other speakers, that has been more revealing of this particular dilemma between autonomy and then distributive justice issues that public health interventions can actually call out within our public sectors. So next slide. So the challenges of COVID-19 have really been on a global scale. This has not been something that is simply isolated to a single community, as you know, but the experience has been very diverse because of that global scale and because it is waxing and waning in waves across our globe and having disruption of not only the local economy, but global supply chains, global health, and resourcing. It also has started as a novel virus. So there's been this evolution of knowledge. And with that comes this huge need for education and building trust. But every time the information is changing, there's an opportunity to undermine that trust. And as you know, there's lots of social media and other areas of communication that can truly build a lot of myth or distrust as you are working to message what is evolving in the scientific realm, as well as recommendations. Additionally, it has been a very politicized year, and particularly across the United States. And so many of the issues that are really being driven by science or best public health practice have been used as a political football and muddies the water, muddies the opportunity for education. It also has revealed very profoundly the fragmented and inequitable systems that exist within the United States, not only in the healthcare systems and some of the siloed approaches that we have had historically, but also just in the access and other equitable issues of race and community and economics. It has, again, been complicated by the communication from our leadership, and some of that has been around politicization, but it has also been just gaining consensus even within communities and people's own belief systems versus being able to rest fully in evidence-based practice. And then those health impacts that we are seeing and trying to mitigate are vying and driving at the same time economic impacts. And Dayton did a beautiful job of looking at those social determinants of health. How do we balance not only what it means to have physical health, but housing, transportation, food security, education, and our schools are a huge piece of food security for our children in and across many communities, making sure that we have jobs and lived environment, and then access to care that can be distributed equitably. Next slide. So when we really look at the ethical perspective of the vaccine that has become available, we really looked at what does it mean to reduce severe morbidity or mortality and the negative societal impact due to the transmission of SARS-CoV-2 or COVID-19. And first, we really needed to define what was the purpose of the vaccine. We know that it is another and probably the most powerful tool that we have in a layered public health preventive approach to preventing the spread and impact of COVID. And yet, while it has been an unprecedented development of this vaccine, and while there are multiple that are coming forward, there are supply chain issues as well as distributive issues. And it needs to be acknowledged that this is ongoing across the whole globe. So how do we address a more phased approach, knowing that we're going to start almost like a trickle of water from a hose, and hopefully slowly we'll begin to increase that flow, but knowing that we have to deal with a very limited resource to begin. And so as we have been through that, there were the three principles that really were driving it is the concept of beneficence, doing right and providing the best for our patients as well as our public, non-maleficence, and then the justice of equitably being able to distribute these vaccines. And I would add in there the fourth, which is truthfulness. And this has been essential to go ahead and message, even if it's not the message we want to hear, that we do have supply and demand issues, that we do have a very limited and precious resource, and that we do have to, again, make choices. We have to start with those who are at highest risk for spread of the disease, contracting the disease, and then severe disease. Next slide. So those considerations we've been walking through are really who is at risk for acquiring that infection. And it would be the originally the frontline workers, those who stand in the gap, willing to care for people who have COVID. Even with PPE and those layered approaches, they're kind of swimming in the virus. And so they are really at risk for not only contracting it, but potentially carrying it home or to the next patient that they see. Also, those who are more at risk for severe course of disease, and we know that those who are 70 and older, those who are in long-term care facilities are the highest risk for fatality, certainly. And if not fatality, severe courses that would require not only long hospital stays and use of resources, but potentially significant morbidity for the individuals as well. And then the transmission of infection to others, we talked about that with our caregivers. And so we had to develop a phased approach. Next. We are in this phased approach now, and I just want to note that since this was submitted maybe 10 days ago, this phased approach has already been altered. We were informed of this at the end of last week by the governor. And so some of these phases are not necessarily within the control of completely the local decision makers. And so our phase 1 has changed into a phase 1B.1, point 2, and point 3. We have opened some of our vaccination opportunities up, and yet at the same time, supply has not increased. And so managing the expectations with that truthfulness that we talked about is an ethical principle that I think is essential so that we can build and continue to build the trust of our population that when the vaccine is available, that they will be receiving it, and that they can trust that there is an equitable distribution, that they won't be bypassed, and that there is thought and science as well as ethics behind how we choose who and when individuals will be vaccinated. Next. So while we're looking at a very limited supply at this point of our vaccine process, we do receive our vaccine into El Paso County. And typically by the end of the week, all of our diverse partners have been able to distribute that vaccine. We have a multi-pronged approach. It has been built mostly on utilizing the resources that are in place and in collaboration, again, that ability to work cross-sector and cross-agency. So we have a pharmacy Safeway and have additionally added King Soopers Peak Vista, Matthews View, Optum as our primary care, UC Health, Children's Hospital, and Centura as our major hospital systems, all are coming together day in and day out to create clinics across the community at various sites to distribute that vaccine. This not only utilizes our resources well, but also gives equitable distribution by creating multiple sites across the community at which people can access. In addition to that, we've been working with mobile sites to bring vaccine to those who maybe don't have transportation or have more limited ability to be able to get out. So our Safeway partner has been and tasked with and bringing those vaccines out to our long-term care facilities. And then while there have not been large pods that have been massive in the way that we saw at the Coors Field up in Denver, we do have one coming up in 2 weeks at the World Arena. And I would say that these are effective, that they have a great visibility and bring awareness to our community, which can promote the vaccine itself. They're kind of sexy, if you would say, but they are a huge lift of resources. And so we will be using some of those, but they are adjunct to all of the day in and day out resources that we need to make available for our patients. So while those vaccines, and there's so many more details we could jump into, I want to leave time though for questions. I have to say that as a public health provider, while vaccines can save lives, so can you. We are just as effective, although it's much more arduous. It is imperative for us to continue those layered preventive measures of wearing our masks, keeping social distancing, having the limited group sizes as we move forward to build our herd immunity and distribute these vaccines. So thank you. As we look and we'll start with our chat, I believe, for answering questions that have been placed there, but please consider what are some ethical considerations for you in your practice or experience that are valuable in addressing from the issues that have been presented today. And how important is it to have a community ethics committee, particularly as we look at disruptive innovations, as we look at collaborations and moving forward with new challenges that will be emerging, not only with COVID, but as we step back from COVID, the issues that will emerge. And then the continued place for those collaborations among our local agencies, academia and community ethics. And how would you suggest that we could more robustly address these challenges? So thank you.
Thank you, Robin. The link between us as individuals and the community are founded on the principles that represent accountability, transparency, respect, support, and mutual trust, which definitely Robin brought up in her presentation, and of course throughout the presentations today. We just want to share with you our actual committee email. So if there's anything particular, if you know or know of an agency that would like for us to conduct a review of an ethical dilemma, here's our email address. And then we're going to move in to some questions, but the committee would really like to thank, again, the Daniels Fund for this opportunity. And thank you for listening and being part of this presentation and the dialogue. And so I think we'll let Tracy facilitate those questions.
We do have some questions, and hopefully some more questions will come in, but the first one is for Dayton. Someone asked, how might families be engaged, strengthened, respected, and trusted for their knowledge and action and treated more fairly in care for their elders now and in the future to increase viability and accountability in elder care? How could families be engaged?
Yeah, it's a phenomenal question, and it's one tough to unpack. for me, but I think in general, education is absolutely key. Staying informed as a family member to be able to kind of speak to the care of your loved one who may be in a facility and receiving some sort of support. So having questions prepared to, have some sort of dialogue with some providers, if it should it be in a healthcare facility setting. I think also being familiar with some of the entities involved with holding our facilities accountable, through a division in CDPHE, there's the Health Facilities and Emergency Medical Services Division that, do the rating and kind of they do the surveys in different facilities who are being on the lookout for the conditions, the living conditions and the state of the residents. And so I think just kind of being informed as even in the decision of, placing a family member into a facility and the cultural fit and when they're going in, all those are variables that you want to ensure that you're kind of making sure that they're in the best position to be successful in their aging process where they're getting placed. In terms of, again, trusted and respected as a family member. I think, unfortunately, situations like a power of attorney and those sort of things are taken advantage of. And so I think the paper trail and holding yourself accountable is also equally as important as caring for your individual. So knowing your own limitations and recognizing and being comfortable in saying what your limitations are and looking to those providers as a support, I think builds a trust that could, build that rapport in terms of accountability and viability for your loved one.
Thank you. Okay, so this question it could be for Robin, but anybody could answer. Why haven't some of these decisions been made in sort of planning phase well before a pandemic hit? It seems like we're responding without any forethought, and knowing that, we can't anticipate what's going to happen. How do we reply to those types of questions?
That's actually a really good question. And I think one of the things that you have to understand, so there is a tremendous amount of planning that goes on around outbreaks and communicable disease. So we routinely run kind of like what we used to do in the ER. You would have a mass casualty event and a mock event and bring in fire, bring in PD, and they would actually have actors who acted as patients, and they would overrun our ER. We would treat them as if they were patients for triage and supplies and treatment, etc. And everybody was called down to do that while we were still running day-to-day operations, which is how real life happens. We do that in public health as well with outbreaks and doing evaluations and testing our systems for communication. I think one of the things around this pandemic in planning for that is that we had some really significant challenges in having leadership at a federal level that was consistently leading down into the state and then local level. At the grassroots level, we would make decisions, and we were learning about this virus at the same time that we were trying to implement, standard prevention, looking for not only that, but how would we treat it? Who was going to be impacted most? How can we minimize the disruption of people's lives while implementing public health measures? And how quickly will it be spread? It took some period of time to even understand the life cycle of this virus. And so we do have infrastructure, and moving that forward while you're learning to be able to build all of the metrics into that is part of a pandemic, I think, by definition. And so while we have a lot of lessons learned, we would would, with the next virus, have some learning curve because the virus itself can dictate a lot by its own biology.
Thank you. I realize that we are at the end of the time, but there's some really good questions. And so if the audience doesn't mind, we'll continue with just a couple. And I'm not sure who's best to answer this. And Carl can chime in because he might have had to leave. But someone asked, we have seen how the restrictions of the COVID have negatively impacted mental health. How do you ethically determine what is more important to protect by implementing regulations or restrictions on individuals to protect physical health as opposed to mental health? That could go to either one of you, whether it be Dr. Traylor, Dayton or Carl. So who would like to answer that one about how do you determine how to protect and the physical health, but keeping in mind mental health?
I'll go ahead and attempt that. I think early on, how rapidly the virus spread and how significantly it impacted physical health, including comorbidity and some of those kinds of things, in addition to the high death rate, that to try to impact that and control that while still being aware of the fact that mental health is very strongly affected through some of the governor's mandates. But I think early on, because how fast the virus spread and how significant it was impacting people's lives, that the push was to look at how we can protect people physically. And now we're becoming far more aware of what the mental impact is, and looking to locate resources in the community to help support that. UCCS has mental health services and resources here on campus for students that have been impacted by the isolation and the frustration of the pandemic. So I think all of us that are in the healthcare arena certainly are aware of the impact of the pandemic on the mental health status of our clients and colleagues that we see. And I think it behooves us to help gear people toward the right resources that are available in their community that they can access.
Thank you.
Can I chime in really quickly to that? I think that we have to be really careful. Absolutely, the mental health and physical health, we have continually been addressing and balancing and calling on the community partners who can help to shore that up, bringing innovation and hope into this situation. We cannot lose sight, though, that the virus itself has tremendous impact on the mental health of individuals who contract it, or the families who lose family members to it, or some of the long haulers and other physical ramifications in the morbidity of it. And so its impact is hitting us on both sides. And that is something that we have to be aware of, that it's not just some of our restrictions or preventive measures, but the virus itself really has had a toll. And we were already dealing with some emerging issues, which I call diseases of despair prior to COVID, which were substance use disorder, depression, suicide, and alcohol related deaths. So we have a significant amount of work and community innovation to do to support and increase grit, as well as behavioral health and resilience. And I would like to just echo, Sarah talked about Chip Benight, but he has a grit program, and some of these other things have really been able to come to the forefront and gain some traction because of more public awareness of the impact of COVID.
Okay, thank you. I'm going to ask one more question just because I think that we should address it. And I know that we're late, and then let's let this be the last question because there's a lot of other comments and questions in the chat. We'll mark them down and we'll see if we can get people some answers. Again, I think that this is going to be to Robin, unfortunately, because the vaccine is on everybody's mind. And the person actually does recognize that the vaccine plan is very robust. But what kind of plan has been developed to quickly get vaccines that are going unused to some sort of backup list of people who are available on demand so they don't get wasted? We hear about that in the news. So what's the plan?
Yeah. So let me tell you, we have worked with locally, and I can speak mostly to our grassroots efforts here in El Paso County, but it is driven mostly by the collaboration of our clinical partners. And from the very beginning of this pandemic, we started a clinical ops group so that we would be aware and educating each other as to what was developing and having consistent and community messages that could help to support all of our citizens. So as we look at the vaccine, we meet 2 or 3 times a week to talk through what our partners are asking for in vaccine supply, what they actually are receiving, what they've been able to set up for distribution, and then also as they look at that distribution, what they're actually getting out. I can tell you Pfizer and Moderna are pretty fragile vaccines. They have a short half-life once you thaw them. And so once you thaw that vial, you need to have 6 patients who are scheduled to get that vaccine, and they need to show up. And so all of our providers have created a list of individuals from, as you get into that queue, they have reached out and say, you're scheduled for Thursday, but we're having a vaccine, events before that. If we call you, are you available within 30 minutes to arrive to get a vaccine? And so honestly, at last discussion with our partners locally, we had not wasted any vaccine due to the strategies that each of our partners are utilizing.
Thank you. And if we can just go to the next slide, please, or we will conclude this event. As I mentioned, there are other questions and comments. Some people have said, oh my gosh, I want to talk to this person a little bit more. Thank you very much for the very, very informative panel. And thank you for our participants and attendees. We have a roundtable next week on career development, and then another ethics roundtable on cybersecurity. And so please look at the Daniels Fund Ethics Initiative website, and maybe we'll have another panel on this topic next year when we, in person maybe, right?
That'd be great.
Yeah.
Thank you so much.